Hello, my name is Debbie Waters, and today I will be sharing with you my DNP Advanced Scholarly Nursing Project titled Danger on the Front Lines: How a System of Failures Led to a Catastrophe During the COVID-19 Pandemic. When researching the COVID-19 pandemic and the dangers faced by American healthcare workers, three themes emerged: response, vulnerabilities, and consequences. The United States was slow in responding to the emerging threat of what would become a global pandemic, a slow response at a time when inaction would be consequential not only for the health and safety of the public, but also the health, safety, and well-being of American healthcare workers. When mitigation strategies to prevent undue death were most desperately needed, the United States found itself woefully and unnecessarily unprepared, and therefore lost valuable time in responding, and responded in a manner that fell far short of public health expert expectations. The pandemic created unprecedented challenges for the United States healthcare system and in turn exposed significant vulnerabilities throughout the healthcare delivery system. Not least among them was the inability to protect frontline healthcare workers from the risk of illness and death from a novel airborne infectious disease. Each individual system failure in pandemic preparedness and the response that followed would have been impactful as a single isolated factor. However, the horde of simultaneous failures led to catastrophic results for healthcare workers and patients alike. While the depths of these vulnerabilities of federal, state, local governments, and healthcare organizations run deep in protecting frontline healthcare workers during the pandemic, the focus of this project was on legislative and regulatory protections and enforcement of regulatory protections that were designed to protect healthcare workers through the provision of safe, sufficient, and effective PPE, in addition to advocating for a robust and effective supply chain infrastructure. The PICO, or problem statement, for this project is: will nursing advocacy for new or improved healthcare policy regarding the United States pandemic response provide future protections for nurses and the patients under their care by ensuring adequate PPE? So let's take a look at the background. On December 30th, 2019, Chinese officials reported to the World Health Organization that a cluster of pneumonia cases of unknown etiology had been identified in Wuhan, China. Chinese officials believed that the infections originated from an open fish market, and that since the market had been shut down and was being sanitized, they should be able to contain the cases. Based upon this information and the significance of global interconnectedness that fosters an environment for rapid spread of infectious disease, the World Health Organization recommended surveillance and public health measures for influenza and severe acute respiratory infections be implemented immediately. The ability of the United States to successfully prevent outbreaks on a national scale was dependent upon pandemic preparedness and rapid deployment of public health measures. The infectious disease, designated as COVID-19 by the World Health Organization, began to spread rapidly across the globe. By January 21st, 2020, the first case of COVID-19 was diagnosed in the United States, followed by a community spread that led to an outbreak in Seattle, Washington. In less than 2 months, the virus would spread to all 50 states. On January 30th, long before the threat of the pandemic was fully appreciated by most Americans, the House of Representatives Committee on Education and Labor submitted a letter to the Department of Labor Secretary Eugene Scalia that raised alarm about the emerging threat of the 2019 novel coronavirus, and they urged the Secretary Scalia to make an infectious disease standard a priority within OSHA. While there remain many unknowns at this time, the committee warned of the dangers to frontline healthcare workers, comparing the risk to that of the 2003 SARS pandemic, where 21% of all cases were in healthcare workers. In addition to calling upon OSHA to prioritize a permanent standard, the committee also called upon them to prepare an emergency temporary standard that could be immediately released in the event that COVID-19 became widespread in the United States, and did indeed present grave danger to healthcare workers. While OSHA and other federal agencies began developing guidance, no action was taken on drafting an ATS. By February 5, 2020, China had nationalized PPE production, which was significant for the United States because we import more than 60% of our PPE from Asia. This was also significant because China commandeered PPE manufacturing plants that were owned by American companies and operating in China, forcing them to increase production but blocking them from desperately needed exported supplies to the United States. On March 5, 2020, the House Committee once again sent a letter to the Department of Labor Secretary Scalia advising that the time had come and it was clear that COVID-19 was going to place healthcare workers in grave danger, and urged OSHA to immediately issue an emergency temporary standard. This was not done at this time. On March 13th, 2020, President Trump issued a proclamation declaring a national emergency concerning the novel coronavirus disease. Through this emergency declaration, federal agencies were empowered to grant regulatory relief, albeit temporary. It enabled healthcare systems to respond to COVID-19. OSHA acted upon this enforcement discretion by relaxing standards that required an N95 or greater respirator for nurses and other frontline healthcare workers, and also suspended the annual fit test requirement for N95s that ensure proper fit and function, which was immediately met with backlash from the ANA and other nursing and professional organizations. By March 17, 2020, PPE shortages began to be reported. In an unprecedented turn of events, frontline healthcare workers began relying on DIY projects to supplement PPE. Photos began to surface of nurses wearing garbage bag, hand-sewn masks, and ski goggles in lieu of approved PPE. On March 18, 2020, President Trump invoked the DPA through the executive order to prioritize the production of medical supplies and equipment within the United States. This relatively short executive order granted the president the authority to prioritize government contracts for supplies over competing interests of manufacturers in the interest of national defense. So simply stated, this order allowed for prioritization and allocation of PPE and ventilators by requiring manufacturers to fulfill government contracts ahead of all others, including exports. March 24, 2020, the first COVID death of an American nurse was reported. Despite all prior knowledge, in April 2020, the United States continued to export PPE, leaving American healthcare workers forced to reuse single-use PPE or in other cases go without it entirely. This was even as 54 other countries had ceased all exports. As recent as February 2020, the United States State Department donated 17.8 tons of medical equipment, including PPE, to China, despite the White House and intelligence committees being briefed in January and February about the threat of COVID-19. By September 22nd of 2020, when this project began, there were reports of 450,517 cases of COVID-19 in healthcare workers and 1,497 deaths. While this number may be startling, it is important to know that due to the limitations in the U.S. disease surveillance and tracking systems, that this number is vastly underestimated. The objectives of this project were to accurately identify the issue or issues that led to the PPE crisis and subsequent increased morbidity and mortality among healthcare workers during the pandemic, to prioritize the issue that had the highest feasibility of being enacted, to develop policy recommendations to address the identified issue, to draft a policy paper with key recommendations and disseminate the paper to key stakeholders, and finally, to advocate for change not only on behalf of nurses, but on behalf of all healthcare workers. There were two policy frameworks that served as the guiding principles for this project. The first is the CDC Polaris model that includes 5 domains to systematically develop and implement policy recommendations for an identified issue. The second model is evidence-informed health policy. This model is an adaptation of Melnick and Feinout-Overholt's evidence-based practice model, with an adaptation made to focus on health policy issues rather than on clinical issues. Despite the high stakes of health policy, decisions are often made and policies are often shaped based upon political influences rather than evidence. While clinical practice evidence is used as a guiding practice, in evidence-informed health policy, evidence is beneficial for educating, informing, and influencing policymakers, and all of this is done while fully appreciating the rapid pace of change in a process that's often inflexible and in an environment that does not historically always rely on evidence. This model utilizes 7 steps to accurately identify the issue and use the best evidence to develop and implement policy change. So what did the literature tell us? First, we have failed to learn from the lessons of previous airborne infectious disease threats. We didn't learn to plan or prepare for a more robust pandemic response or to promulgate a permanent airborne infectious disease standard. While tensions were high and there were calls demanding change early on after each threat began, those calls quickly died down once the threat had passed, leaving us no more prepared for this pandemic than any of the other prior threats. There was a failure to heed the early warnings in the pandemic. By failing to respond early and stopping all PPE exports and increasing imports to have stockpiles, there was a failure of healthcare systems not only to follow prior guidance provided by the CDC and OSHA, to have emergency stockpiles of PPE, but also to quickly move away from the just-in-time supply chain management to rapidly procure supplies. And there was a failure to issue an emergency temporary standard immediately upon the increase of morbidity or mortality among healthcare workers, when it was clear that healthcare workers were being placed in danger from the COVID-19 exposures. There was a failure to fully invoke the DPA. This is an area that deserves more research to answer the questions of if it would have even been feasible given the actions of other countries who stopped exports of raw materials. Do we even have a means for domestic production in the absence of raw material imports? While it was not fully invoked, it is questionable if it would have really mattered. Strategic national stockpile limitations. The SNS, long believed to be by many outside of the federal government the mechanism that would provide much needed supplies in an emergency. However, what was underappreciated was the ability of the SNS to respond to a national emergency that involved all 56 states, tribes, and territories simultaneously. The SNS was not necessarily designed for this and had certainly not planned for it in full and thorough exercises. The SNS also relies on public health infrastructure. This is an infrastructure that has been underfunded and neglected for many years. The SNS is another area of focus that deserves further study in the true intent of the SNS legislation. However, that was beyond the current scope of this project. There was a failure to address the nation's reliance on Asia for PPE imports. The United States receives more than 60% of our PPE from Asia, and the expectation is that just-in-time supply chain management is sufficient and helps keep costs low. This led to the limited availability of supplies for American hospitals. There was significant price gouging, and even worse, there were counterfeit supplies landing in the hands of frontline healthcare workers. There was a failure to address workplace safety within the healthcare industry. Interestingly enough, the healthcare industry is the largest employment sector of the United States, and there is only one workplace standard that is specific to the healthcare industry, and that is the bloodborne pathogen standards, or universal precautions. There are no workplace safety standards to address airborne infectious diseases. While there are existing PPE and respiratory protection standards, those are both general industry standards and do not address biological threats. While working through the problem identification process and through examining what was causing the underlying problem of nurses becoming sick and dying from COVID-19, an entirely new focus emerged with the examination of what workplace protections should have been in place to protect all healthcare workers. These two policy models were integrated into the DNP project to identify the true issue or issues and then to evaluate the policy options. In this project, two issues emerged, with one being supply chain management disruptions and the other being inadequacy of federal workplace safety standards. The policy options were then viewed through the lens of three key interrelated criteria, including the public health impact, or what impact will the policy options have on the quality of life and morbidity and mortality of the affected population, which in this case is frontline healthcare workers, the feasibility, or what is the likelihood that the policy recommendations can be successfully enacted and implemented, with a keen focus on the realities of the political climate and political history, in addition to the wherewithal of stakeholders both in support and opposition. And finally, the economic or budgetary impact of the policy recommendations, and evaluating if the benefits of the policy actions outweigh the cost of policy enactment, implementation, and enforcement. The literature review revealed vulnerabilities not only in the nation's healthcare systems, but also in the regulatory bodies that enforce workplace safety. Based upon this information and the current political climate, the determination was made to prioritize workplace safety standards first through an emergency temporary standard for immediate protections, followed by a permanent airborne infectious disease standard. The final product was a policy paper titled Policy Recommendations for Protecting Healthcare Workers from Future Airborne Infectious Disease Threats, Lessons Learned from the COVID-19 Pandemic. This policy paper outlined 4 key policy recommendations with supporting rationale to provide safe and equitable workplace health and safety conditions for healthcare workers. The policy recommendations were chosen after in-depth research on existing workplace standards, the limitation of those standards in protecting healthcare workers from the dangers of being exposed to airborne infectious diseases as a workplace hazard, and the lessons learned throughout the COVID-19 pandemic. The recommendations were prioritized and presented in the order of most through least effective in mitigating the risk to healthcare workers throughout the remainder of the pandemic and against future inevitable threats. The recommendations were, number one, OSHA should immediately reinstate and enforce the COVID-19 healthcare emergency temporary standard until it is superseded with a permanent airborne infectious disease standard. This is, of course, the highest recommendation because it is indeed the most comprehensive and effective way to protect all healthcare workers from future airborne infectious diseases, as well as the remainder of the COVID-19 pandemic. Number two, Congress must act in a timely manner to protect the health and safety of healthcare workers. Congress may act through a number of legislative or committee actions to try to compel OSHA to act and to clarify ambiguity in the legislation. For example, the 6-month time frame for an ETS to be replaced with a permanent standard shows that the current law is inconsistent with the time it takes to promulgate a new standard, and the law lacks a consequence if the 6-month time frame is not met. Where there is ambiguity in the law, it is incumbent upon Congress to provide clarity. Congress must act by allocating necessary funds for OSHA to effectively enforce workplace safety standards. Throughout the pandemic, OSHA lacked the workforce necessary to conduct on-site inspections and enforcement activities. Number three, OSHA could revise and expand the existing respiratory protection standard to include specific requirements for the healthcare industry in addressing biological hazards. The existing respiratory standard is a general industry standard and is designed to protect workers from noxious gases, fumes, and chemical exposures, and it does not include airborne transmission of biological hazards that cannot be contained and do not have permissible levels of safe exposure. An important part of this would be to include N95 respirators for all unknown and novel diseases and pandemic influenza until there is definitive evidence that supports that the threat is not airborne. The final recommendation, implement airborne infectious disease standards at the state level with oversight and enforcement by state occupational and health and safety plans in all states and territories. This final recommendation has significant limitations. While the OSHA Act of 1970 grants authority to states and territories to regulate and enforce occupational safety and health, currently less than 1/2 of states have chosen to do so, and of those states, only 4 issued standards that specifically address the dangers associated with COVID-19. The inconsistent state structure is inhibitive in providing adequate workplace protections on a national scale and leaves a large percentage of healthcare workers with limited protections based solely on geographic location. COVID-19 has established that airborne infectious diseases are not contained by state boundaries, and therefore establishing workplace safety standards that provide equal protections would require collective action that's consistent from state to state. So while this seems like a heavy lift and a lengthy process, it would seem that time could be better spent on promulgating a national permanent standard. This project was unable to be fully evaluated due to the time confines and the length of time required for a policy change. And while it is promising that OSHA is talking about the issue, we also know that healthcare workers remain without an enforceable workplace safety standard. We know that the number of healthcare worker cases and deaths from COVID-19 have doubled throughout this project. And we know that the healthcare industry, historically the leader in the number of workplace illnesses and injuries, saw that rate increase by 249% in 2020. While we know that the need is there, the reality is that the slow churn of policymaking process means the full impact of this project may not be known for months, years, or even decades down the road. This is the one key limitations of completing a health policy project. This project began within the first 6 months of the pandemic becoming widespread throughout the United States and concluded as it continued along an unknown trajectory with no definitive end in sight. This was a very interesting time in history as more than a century had passed since the United States experienced a pandemic of this proportion. The environment was dynamic and rapidly changing with many challenges, including a limited but growing body of evidence, the transition of power of the executive branch through the election of a new president, state and local government shutdowns, public and political discourse, widespread misinformation, a worsening nursing shortage, and a lack of trust in leading healthcare scientists and experts. Despite these challenges, this project succeeded in ensuring the voice of the nursing profession was heard. This project also demonstrated that it is incumbent upon all nurses and leaders in healthcare to demand a seat at the table where decisions are being made and to advocate for change that ultimately protects the lives of healthcare workers and the patients whom we serve. I will end here with a quote that I heard early on in my research, and that is, "Every virus has a story to tell. We just don't know how this one ends." Let's hope this story this virus tells is one of nursing banding together in strength and a unified voice to demand that unnecessary loss of life seen throughout the COVID-19 pandemic is never allowed to happen again. Thank you.